event. Okay. The key thinking error usually present in the GAD, which is overestimate the probability of the negative events, which is the example like estimate like, for example, the like economy is the bad and we could lose job and it will cause the damaging to the life. Another thing is the overestimate the severity of the negative events, which is like someone do a one mistake but he thought the mistake was a very excessive mistakes. Okay, move on to the slide. Which is belief that support the chronic worry. So what is the perfectionism? Perfectionism is the belief that someone should not make any mistake, and like in the judgment or in the decision makings. This making error will present that a person is incompetent. So a person will be feel the pressure to make a right decision all the time. And the other things about the chronic worry is the responsibility, which is that we might feel that if we are not responsible or irresponsible if we are not focused on the negative possibilities. And other thought is the demand for control, which is the controllability. We believe that a worry in the gaining control is to prevent the negative outcome from getting through, which is like seeking the reassurance. Okay, move on to the diagnostic criteria. For the diagnostic criteria and the GAD, which is the criteria A, the excessive anxiety and worry, apprehensive expectation occurring more than not for at least 6 months, which is a number of event activities happens. And for criteria B, the individual finds it difficult to control the worry. And for the criteria C, the anxiety and worry are associated with the 3 or more for the following 6 symptoms, which at least some symptoms have been present for more days and not for the past 6 months. And for the children, only one symptom is acquired. For the symptoms, the restlessness or kiap on the edge, being easily fatigued, difficulty concentrating or mind going blank, irritability, muscle tension, and sleep disturbance. For the criteria D of the anxiety, generalized anxiety disorder, the anxiety and worry physical symptom are cause clinically significant distress or impact in social, occupational, or other important areas of the functioning. Criteria E, the disturbance is not attributed to the physiological effect of a substance, which is a example like drug or medications or other medical conditions. And for the last criteria, which is the F, this is the disturbance is not better explained by another mental disorder. So for the cognitive distortion, which is the present in the generalized anxiety disorder, it can be divided into some thoughts like all or nothing thinking, which is anxiety of the thinking whether if she doesn't become a champion, she will think that she become a loser. And overgeneralization, which is a thought of cognitive distortion that happen. For example, like if someone having a bad at one particular thing, and he will think that he will be bad at the other thing that he do. For example, like he probably bad at one public speaking, and he will think that he will be bad for all the public speaking for the future that he will have. And for the mental filtering, she be thinking about the bad things and ignore the good things, like a boss giving a compliment to his workers and with only comment, but he only focus on the comments. And for other is the disqualifying the positive, which is if someone giving the compliment to him, he or she might think that the compliment might be sarcastically true, and he or she might think that the compliment isn't true at all. Another thing is the jumping to the conclusion, which can be divided into fortune telling and mind reading, which is assuming that someone is have a thought on him, which is could be like assuming that he or she is the annoyed, or he or she is thinking a bad about you. And other is the magnification and minimization, also can be known as the catastrophic, which is someone think about he make a probably small mistake, but he think that a mistake is a big mistake. And other is the emotional reasoning, which is could be from the reason why someone if mad at you. For example, is the someone is might feel jealous and insecure, and you might think that he or she might be cheating on you, and even though it doesn't have any evidence. And should treatment is the feels that feel of doing everything is not good enough. Which mean that if we're doing an assignment, we think that the assignment was not good enough and will cause anxiety. And the labeling is the thing him or herself of something that he only had one, he or she is not. Like he only had one bad experience. Like probably he answered the question is wrong, and he or she might think that himself look stupid or something like that. And lastly is the personalizations. With it, for example, is someone, for example, someone is like doesn't talk to you, and you must think that you must have done something wrong, that he or she might hate you for that. So we have lastly is the treatment, which is the treatment for the component of the GAD, which is can be divided into three: physical, cognitive, and behavior. And for the physical, we have the progressive muscle relaxations. And for the cognitive, we have the disputes worries by identifying their realistic odds, decatastrophizing the technique. For cognitive, we can first step we can do is the identify the specific worries, and second is we have to evaluate the real odds of the negative prediction coming true, and we have to then we have to picture that the realistic scenario from our predictions, and we have to imagine, and other than that we can also imagine the worst case scenario and ask the person himself to rate the severity of the scenario. And also we can do lastly we can do is we can tell the person is to picture how he or she to cope with the worst case scenario if it happens. And for the behavior we can do is the reduce assurance seeking, counteract the problem, and teach a problem solving skill. Just on the behavior, we have to tolerate the imperfections, just letting go the sense of irresponsibility for unlikely event. And usually we do is the behavior change, but behavior change usually do after the coping skills with the realization and thinking realistically. That's all for my presentation of the generalized anxiety disorder.
Okay, I think can continue with the second and third presenter first. Okay, sebentar tu mungkin I komen dulu. Okay, so I think generally in while the second presenter will be sharing her slide. Okay, I think mental illness generally can be divided into the severe mental illness or the psychosis and the neurosis. So for the severe mental illness or psychosis, uh, the main the prototype is the schizophrenia spectrum disorder, and then usually you need to understand the phenomenology, all the things that you learn, such as the definition of hallucination, delusion, and so on. But for neurosis, the prototype is the anxiety. So the anxiety is probably the most common and most important type of neurosis. And of course, there is further classification of the anxiety disorders. So for anxiety disorders or anxiety or neurosis, um, if you only understand the general psychiatry, so you will be stuck at the level of general symptom like anxiety and so on. And usually, even in the diagnostic classification, you see that the type of symptoms in anxiety disorders can be divided into the psychological, very broadly can be divided into two, lah, the psychological symptoms and the somatic symptoms. Okay. Very broadly can be divided into two. But you can further divide from the perspective of cognitive behavior theory. You can further divide into 3 or 4 components. So which is interacting between each other. So this is the thought component or the worry, and then the emotion component or the fear, and then the somatic or the physical component, all this palpitation, ventilation, paresthesia, everything lah, breathless, and then the last one, the behavior component. So these 4 component, like in a circle, each one can become a positive feedback to the next one. So by understanding this interrelationship between the component, it allows us to think about the possible intervention to break the vicious cycle. So this is like a vicious cycle. So each one will become the positive feedback for the next one, and it become vicious cycle becoming more and more severe. So we can break the cycle and therefore can improve the outcome of the patient. Okay, for example, patient behavior and behavior like reaction seeking. So you can do some form of behavior modification at that level. Patient having excessive worry, so you can probably train patient not to identify their cognitive biases and correct those biases, and also those negative emotions, physical symptom can also be treated psychologically or using pharmacological treatments. So that's how we should understand um, how to treat anxiety disorders in a more holistic way. And of course, as the first presenter mentioned, the things that can contribute to the maintenance of this anxiety is perfectionist trait. So people with perfectionist trait, they always worry of the future outcome, and therefore they must control the current situation the best that they can do. But unfortunately, this relentless pursuit of perfectionism can never be satisfied because the future is still unpredictable. So it may be initially adaptive and causing some form of sense of control, but eventually it become out of hand. Okay, for example, maybe as a student, you feel that you can control to a certain degree the outcome in 1 or 2 months time, but as you become more older and exposed to more variability in this world, or if you are encountering a lot of conflict or any life event, so you will be quickly feel that things become out of control and you cannot control the current situation as to control the future outcome. So that's how um, sometimes the trait of perfectionism can maintain and worsen the anxiety. Okay, I think we continue with the second presenter.
Assalamualaikum and good afternoon to fellow friends and also to Prof. Next, we will proceed to the second topic, which is panic disorder. So, by definition, uh, by Kaplan and Sadok's psychiatry textbook, define panic disorder is an acute intense attack anxiety accompanied by feelings of impending doom. So the anxiety is characterized by discrete periods of intense fear that can vary from several attacks during one day to only a few attacks during a year. Patients with panic disorder present with a number of comorbid conditions, most commonly agoraphobia. Agoraphobia refers to a fear of or anxiety regarding places from which escape might be difficult. For example, being in a train. Okay. Next. So, when we talk about panic disorder, there are several clinical features that is shown by the individuals. These clinical features are obtained from the video that we refer. So, panic attack can be defined by 4 or more of the following symptoms. We divide into 11 somatics and also 2 cognitive symptoms. The somatic symptoms include increased heart rate, shortness of breath, chest pain, choking sensation, sweating, trembling, nausea, dizziness, feeling numbness or tingling, hot flashes and chills, and also depersonalization. And 2 cognitive symptoms include fear of dying and also fear of losing control. So basically, these clinical features are the our fight or flight response towards perceived stressful or frightening condition. This is basically a uh, normal response for normal individuals, but with patient or individuals with panic disorder, they develop this kind of clinical features, increased heart rate, shortness of breath, without the presence of stimulus. Okay, next. So, a brief regarding the diagnostic criteria based on the DSM-5 for panic disorder. For criterion A, recurrent unexpected panic attacks. A panic attack is an abrupt surge of intense fear or intense discomfort that reach a peak within minutes, and during which time 4 or more of the following symptoms occur. So, as listed here, 4 or more of the following symptoms. Okay, next. For criterion B, at least one of the attacks has been followed by 1 month or more of one or both of the following. First, a persistent concern or worry about additional panic attacks or their consequences, for example, losing control or having a heart attack or going crazy. Secondly, a significant maladaptive change in behavior related to the attacks. For example, behaviors that been designed to avoid having the panic attacks. Okay, for criterion C, the disturbance is not attributable to the physiological effects of a substance or another medical condition. And for criterion D, the disturbance is not better explained by another mental disorder. Okay, next. So, based on the video, what we learned is that to approach panic disorder, we can go through from 2 perspectives, which is cognitive and behavioral perspective. For cognitive, in individuals with panic disorder, they are prone to get panic attacks, firstly, of course, and at the same time, they misinterpret the bodily sensations that develop when they are in panic is harmful. They misinterpret them. And since panic attack, as what mentioned previously, they came without the presence of stimulus, they will be more focused on their body sensation and not on the stimulus because, yeah, there's no stimulus. So they will interpret this bodily sensation as potentially harmful. This misinterpretation also come along with catastrophic thoughts. For example, fears of death or disability, fears of losing control or insanity, and also fears of humiliation or embarrassment. So, as for example, when individuals develop a panic attack, they will have rapid breathing, increase in heart rate, shortness of breath, feeling nauseated, and dizziness. They will think, am I going to have, am I having a heart attack? Am I going to die? Am I having a severe mental illness? They will think like they want to scream. So this talk, what we need to tackle during this therapy. So the role of cognitive therapy, firstly, is to educate patients about panic in general. Try to educate patients how to recognize the symptoms of the panic attack, such as palpitations, shortness of breath, sweating, dizziness, all of those 13 symptoms mentioned previously. Try to recognize them and not having the catastrophic thought about these bodily sensations, because they are basically a normal reaction towards a stressor, towards a frightening condition. Secondly is to identify the possible triggers for the attacks. Next is attempts to correct these misinterpretations of the sensations by suggesting an alternative interpretation. Like when they say they are going to die, they are going to die because of this palpitation. So we say that basically this reaction is normal, and you are not going to die because of this. They are not in danger. They will not faint because of this reaction. And lastly is to reassure that the sensations are not harmful. Okay, next. Uh, the next perspective is we look through behavior. So in individuals with panic disorder, they prone to present with palpitation, rapid breathing, and also dizziness. And in severe cases, they will try to avoid the situations or experiences that might risk another attack. And they will also develop behavior specifically developed to avoid these uh, situations and experience that might trigger another panic attack. So, how to tackle this kind of issues through behavioral therapy is to promote mindful and controlled breathing. And then we develop a hierarchy of situations that might trigger panic from the least stressful to the most stressful. And then we ask the patient to gradually face the situations from the very least. Based on our lecture this afternoon, this method is also called systemic desensitization. In order to make the patient become make the patient familiarize with the condition that might trigger them to be in panic attack. And then we also can expose the patients to the fearful situations more than once. And then we ask them to stay in the fearful situations long enough until the anxiety go down. So this will help patient to control and rethink their thought, make sure that their reaction is not over. And lastly is interoceptive exposure. This is when we trigger the same sensation during attacks, but in a controlled setting. For example, we make patient develop palpitation or rapid breathing. And then we give opportunity for the patient to habituate the sensation and retain their perception during that condition. So this will slowly, the patient will slowly learn how to control their behavior when having panic attack, and also to think wisely, not catastrophically. Okay, next. Yeah, I think that's all from me. Thank you.
Okay, thank you, Amirul. Okay, so the first one was GAD. So in GAD, the hallmark of GAD is worry or anxiety lah. Worry lah, maknanya risau kan. Worry is more of thinking about threat in future, threat that has not present itself in front of you. So this is the essence of worry. And then this worry, if excessive and pathological, it becomes the generalized anxiety disorder. So more intense than worry. So you have fear. So fear means you also have a threat. Ancaman kan, threat. But now the threat is in present, probably in front of you. When there is the pathological form of fear is what you call as phobia. So meaning that you overestimate the probability and severity of threat in front of you at present. So in the pathological form, you call it as phobia. And this phobia cause fear, which is felt in the amygdala, and as well as somatic symptoms like palpitation, your part of flight response. And at the peak of the more intense than fear is the panic. So panic means this fear response, sometimes it comes by itself without any apparent trigger. So conceptually, your panic is much more severe than the fear, because fear, in a way, this is more predictable, so you can avoid encountering the trigger or the phobic stimulus. But for the panic, this is more out of control, because in panic, usually the fear itself comes without any relation to the surrounding. It comes by itself. And this panic, when the pathological form of panic is your panic disorder. So itu macam tu lah. So you start from the lower down, the lower down less severe your anxiety, and then your fear, and then the peak is the panic. So in panic, so in a way, panic is like phobia, but usually when we talk about phobia, there is identifiable phobic stimulus in the surrounding. For example, like poisonous animal, crowded situation, or apa-apa lah. But the point is, these are the situation in which we subconsciously identify or misidentify the presence of threat. Kan? Macam ada survival values lah. Maknanya, of course, it is of survival values to be afraid of poisonous animal. But in the pathological form, this threat is overestimated. Okay. So, however, in panic, actually, if we look closely, actually the trigger is interoceptive sensation. So meaning that this patient, they become afraid of the fear response itself. So all these palpitation, breathlessness, depersonalization, all this represent the somatic manifestation of fear. So they overestimate the seriousness of this fear response, and this overestimation of fear become a positive feedback that cause the fear to become more severe. Jadi macam itulah maksudnya. Jadi also if you look in pathophysiology of panic, it also involve things like hyperventilation. So when patient becomes as the patient become more anxious, he will overventilate more than he will overventilate and losing more carbon dioxide and become respiratory alkalosis. So this respiratory alkalosis will cause some disturbance, causing symptoms like paresthesia of the extremities, lightheadedness, and the feeling of giddiness. So all this will be interpreted as validating their worry that they might fall down, for example. And this further cause the symptom, the worry to become more intense. And the more worry means more hyperventilation, more sympathetic overactivation, and causing yet more severe physical manifestation of anxiety. So maknanya dalam panic ni, the hallmark is the somatic symptoms lah. So the somatic symptom, the physical the somatic symptom is the most prominent symptoms in panic. Although they also have this worry, but their worry in panic is specifically towards having additional panic attack. In contrast, in GAD, their worry is more generalized to all the day-to-day problem. But in panic disorder, it is focused more on the prospect of getting additional panic attack. So, maknanya kalau in term of treatment, you want to break the cycle. So basically, you want to break the cycle either at the level of thinking or at the level of behavior, whatever that you can do lah. Jadi contohnya, because you know this overbreathing or hyperventilation is contribute to the pathogenesis or pathophysiology of this panic. So you may want to teach patient to the technique for controlled slow breathing ataupun apa lagi. So also you have to teach the patient to have sense of mastery over their interoceptive sensation. So they should not be catastrophizing palpitation. Jadi maknanya this patient will panic. If they are very severe, they will avoid climbing flight of stairs, for example, because all this palpitation, they become very fearful. They fear that this palpitation will become out of control and can trigger episode of panic. So they don't want to do exercise and apa-apalah, whatever things that can cause increase in heart rate. Okay, I think we continue with the third presenter.
Okay, so good afternoon to Prof and my fellow friends. My name is Swarna and I'm from Group 3. There will be 3 of us discussing about social anxiety disorder. Slide. Okay, so as for definition, based on Kaplan and Saddox, social anxiety disorder is the fear of social situations, including situations that involve scrutiny or contact with strangers. And another definition by NCBI, it is a persistent fear of one or more social situations where embarrassment may occur and the fear or anxiety is out of proportion to the actual threat posed by the social situation as determined by the person's cultural norms. So here is the flow of how social anxiety is in a patient. As the name suggests, there is an intense fear of social situations, and because of that, the patient will tend to avoid the situation that triggers the anxiety, leading to interference with the person's daily functioning, whether it being in their work, daily living, or education. Next. Okay, so based on the videos, these are some of the symptoms that we managed to group. So for the cognitive or the thinking, the patient has a belief that others have judgment or negative opinion on them. And thus, this will lead them to constantly monitor on what type of impression they are making on people. As for feelings, patients tend to be awkward and shy in social situations, and they also exhibit some physical symptoms such as blushing, sweating, trembling, nausea, rapid heartbeat or tachycardia, shortness of breath, lightheadedness, and also loss of control. These physical symptoms, the patients assume that it is being overly displayed. They overestimate, they assume that everyone can see these physical symptoms, and hence they have an increased fear of being judged. Okay, now I'll pass on the presentation to Eugene.
Very good afternoon to everybody. I'm Yijing. Right, so next I'll proceed with the subtypes of social anxiety disorders based on video. So it can actually be differentiated, classified into three kinds. The first kind is general fear of social interaction. Second is being a spotlight in a performance arena. And the third one is observational fear. So as for the first subtype, for general fear of social interaction, so basically it's mostly everything. You go outside, you join a party, you join a class, you join a conversation, right? And the second one in performance arena, normally this will include being a spotlight in the middle of a group of people, such as being a presenter inside a workplace or even in your classroom, or maybe performing on the stage. And also the third one, observational fear. This fear originates from your observation. So for example, when you see someone pour over a glass in a restaurant and make a mess and make a fuss out of it, and you become getting scared and afraid of doing the same things, and you are afraid of uh, get hold of a glass of water in the restaurant because you are afraid that you do something embarrassing as what you have seen before. Right, next. Right, so in short, social anxiety disorder is not a form of shyness. So everybody actually has shyness in them, but as long as it doesn't affect your functioning, it wouldn't become a disorder. So this is an example. On the day one of work, when you are exposed to a new working environment and also new colleagues, for sure every one of us will be nervous. So everybody will be anxious, or anxiety level will be high. But then sooner or later you get used to your workplace, you get familiar with your colleagues, your boss, and sooner and later you will not be anxious anymore. But as for social anxiety patients, they are actually having that kind of anxiety level at a peak at all times, no matter after how long. Normally, if according to DSM-5 criteria, normally it'll have to happen over more than 6 months. And also the sufferer, the patient, will recognize that it is excessive and unreasonable. It is exaggerated, the fear is exaggerated in proportion to the levels of harm that it can bring. But then they cannot control their feelings of anxiety. And it is normally linked to difficulty in educational achievement and also lower lifetime earnings based on reports. And also it is also related to an increased risk of medical problems and also depression. Next. So basically, two causes of social anxiety disorders could be identified. First one is the mix of genetics and also environment, whereas the second one is also is painful childhood memories or experiences. So as for first one is straightforward. Maybe you have a close relative, you have a family history of social anxiety disorder, or you have been exposed to neglect or abuse. And yeah, that's it. So we'll go to the next slide. So for social anxiety disorder, there's actually a model to explain how it happens and what kind of symptoms it'll exhibit. So it can be classified into three components. The first one is physical symptoms. Second one is the cognition of the patient or the cognitive symptoms. And the third one will be the behavior of the patient, or patient will exhibit some of the behavioral symptoms. As for physical symptoms, you can take a look from outside. Patient, whether a patient is blushing, the patient feels that he is having a fast heartbeat, or maybe sinking sensation of the gut. So as the previous presenters have already said, for in general, the people with anxiety disorder normally overestimates the visibility of their anxiety symptoms, which means actually people from the outside couldn't really see that they are anxious, such as when you are having sweat on your palm when you are nervous, but then you yourself perceive that you are drizzling and also sweating as if it is raining overhead. And patients will also have catastrophizing thoughts, which they are consist of three components. Basically, it is covered in the previous presenters also in generalized anxiety disorder. The first one is a negative prediction about future, where that you predict everything negatively, even if you don't have evidence. For example, you predict that the presentation in the afternoon or at night you're going to have, it will go really, really bad. The second one is emotional reasoning. This one you don't have a this actually means that you don't have a rational thinking, but then your reasoning and what you do and what you think are based on your emotions. For example, you're sad, so you think that everything will go bad. And the third one will be disqualifying the positives. This one, it means that something positive happens around you, but then you perceive that it is just like out of norm, or it is just out of luck. For example, if your friends are, if you are talking to your friends and they like you very much, you don't perceive that as they like you, but then you perceive that it is just out of luck or out of sudden. And the third one is behavioral symptoms. So patients with social anxiety disorder normally will present of these three kinds of symptoms. The first one is avoidance, which the patient avoid in social interactions or avoid performances. And the second one is safety behavior. Even if the in this context, even if the patient doesn't avoid attending these kind of events, uh, he will have this kind of safety behavior where he will find his own comfort zone, such as speaking to a particularly one or two close friends. And the third one will be social skills. They believe that they have poor social skills, such as, for example, they believe that when they're making a joke, no one finds it funny, then they believe that they have some social deficits. But then reports show that it is actually not true. Patients who have social anxiety disorder do not have any poor social skills. Right. So I'll pass it on to the next presenter, Azima.
Okay, Assalamualaikum and good evening everyone. Okay, I will be presenting about the treatments part from the video. Okay, so basically we know that patients with social anxiety have troubles regarding their thinking, and it's shown in their behavior. So what is the aim of the treatment for this social anxiety? The aim is we want to guide them and we want them to develop new coping skills, which is facing their fear. Number one, they first we determine if they really suffer from the social anxiety. For example, in patient with social anxiety, they have this specific criteria. We all know that we all have social anxiety, but people with social anxiety have more severe outcome. Okay, the first thing, we recognize fear in the patient. If there is excessive, or most people would not be frightened in similar situation. For example, we're talking about patient doesn't want to go to the cafe and buy food because they are afraid they will spill the drinks and everything. But actually, in the other people, it's just normal. Okay, so in this patient, they tend to avoid situation that cause anxiety, and it cause a great distress. They feel like they can't go to the cafe and so on. They feel like they will be judged by others. Also, this also interfere with person life. It's a person life which keep them from dating, do well in school or work. Number two, in this treatment, we also will determine if they're ready to start the treatment. We want to motivate them in order to change the perspective of them. We want to change their thought, because their thought is actually the positive factor of their anxiety disorder. Okay, and then for the third point, we will pinpoint the situation that trigger the anxiety. For example, we create a list. Okay, what situation that trigger your anxiety? For example, maybe presenting in front of other people, maybe going to a party. So we'll make a list, and also we make a hierarchy. Which of the situation is actually the most fear, the most they fear. And then we also identify the physical symptoms. If they are blushing, if there is shortness of breath, palpitation, and number five, identify the thoughts. Okay, so we know that they said they had anxiety in this certain situation, right? So we help to create more positive thoughts and counteract the negative thinking. For example, they feel that going to the ward, for example, they feel like everyone in the patient will judge them, that they don't plug really well. So we try to counteract the negative thinking. Uh, is it really true that patient thinks like that? Okay, and then number six, us to take. We ask them to take the social situation that frighten them, but gradually. We expose them to the social situation gradually, like facing the fear. Usually when we have problem, we don't run away from the problem, but we face them, we look for the how to solve it. We face fear to overcome, and then we also do a role play regarding the situation that they are afraid of. And after they successfully going through the situation, we give them reward. Okay, next slide. So regarding cognitive behavioral therapy, there are two parts, which is cognitive restructuring and also behavior therapy. Okay, so for the cognitive restructuring, we know that cognitive is the way they're thinking. So we identify any distortions in thinking, either fortune telling thoughts or emotional reasoning thoughts. For example, patient might feel like, oh, I feel like I'm the way I dress is foolish. I feel like I'm foolish. I must look foolish because of the way I feel. So it's actually not true, because it doesn't mean that when you look foolish, then other people will perceive you as foolish. Okay, and then about the fortune telling thoughts. For example, if you go to the ward and then a doctor will be mad at you, uh, actually it's not true, because it will only be mad because when you don't prepare. And then number two, learn about common biases in thought, false equivalency. This actually like, because people with anxiety, they common biases in thought. They tend to perceive their thoughts as negative as possible. For example, if they look nervous, uh, as we all know, it's normal to look nervous. We all nervous. It's either it, it shows or not. So when they thought that they thought they are nervous, so they feel that they are foolish. People will judge them. Okay, so in this cognitive restructuring, we will treat the thoughts as guesses or hypotheses about the world. And then we will apply more accurate and adaptive thoughts, which is like they say that they look nervous and they will look foolish, right? So we change the thoughts. We change the thought with the adaptive thoughts, um which we try to say that it doesn't matter. Nervous is normal. It doesn't mean that we will look foolish like that. Next slide. Okay. This one is for behavior therapy. Okay, just now after we identify the sources, the factors that triggers the social anxiety in this patient, so we provide a therapy, behavior therapy, which is exposure. The goals in the behavior therapy is actually chance to learn social situations that are safe, and that they learn to know that social situation is actually safe, not like what they thought. Chance to learn that assume social cost of errors are lower than expected is not what like they expected to be. And then it's a chance to redirect the attention to others rather than self. Because patient with social anxiety or anxiety disorder, they actually thinks a lot what would other things about themselves. So we try to redirect the attention. Okay, for the intervention, just like I said, provide the rationale in confronting feared situation that is actually what is actually the worst outcome of their feared situation. And then we establish the hierarchy, and also we provide the accurate expectation that it although they think it like that, it doesn't mean it will happen. And then we reduce use of safety behaviors because patients with anxiety, they tend to avoid, right? So they tend to take the safe road, but it's actually not good for them because they didn't face the fear. So we reduce the use of safety behavior and expose them gradually to the social trigger situation. And also we try to help them notice what others do because this will interrupt them from self-focused attention, to overthinking about themselves. Also, after we expose them to these social triggers gradually, we will attend the disconfirmation of fears. Okay, what do you get from actually this exposure? So, in long term, this patient will think that even though I am anxious, I meet my goals. My anxiety is actually brave. Okay, next slide. Okay, so after doing this in a long term, patient will actually know how to deal with their anxiety. Okay, so after patient is stabilized, we have basic relapse prevention. Okay, number one, we avoid avoidance. This is we try to decrease the avoidance to zero, even if it means to experience some anxiety. Number two, we thought challenging strategy. Whenever they think that, oh, I'm anxious to go to this situation, I'm anxious to go to the crowd, we think it as a challenging. We challenge ourselves. It's like the opportunity to deal with. Number three, just like I said, view anxiety as an opportunity to deal with. Number four, we reward themselves or yourself for your success after we going through the social anxiety situation, and because this will motivate ourselves to keep moving on throughout the journey. Okay, next slide. Okay, so for the outcome, patient will thought that I'm no longer anxious, worried, or feel behind on anything. So there's no one person in this world that can make me feel like I need to chase them. No one can judge me, and so on. At this time, patient can, from the cognitive behavior therapy, patient can actually overcome their symptoms. I think that's all from me. Thank you.
Okay, thank you, all the presenters. Okay, so now I want to explain. There are three types of panic attack. Okay, three types of panic attack. The first one is this can be read from textbook lah, traditional textbook. The first type of panic is what you call as uncued or spontaneous. So this is characteristically occur in panic disorder. Uncued or spontaneous means that from observer's point of view, the panic attack occur by itself. It is not caused by any specific situation or caused by any external factors. But upon closer inspection, actually for this uncued or spontaneous, so actually the trigger is interoceptive triggers. So this characteristically occur in panic disorder, especially for the first few episodes. The first one or the second one or the third one. Usually the first few episodes are classically uncued or spontaneous. Even sometimes patient may develop panic attack that awaken them from sleep. So this is very spontaneous, meaning that this is not preceded by or triggered by any event in the external world. This is totally from within the patient. So upon closer inspection, this is because of misinterpretation and catastrophizing thoughts about internal sensation like palpitation, breathlessness, and so on. Okay, and then the second type is situationally predisposed, meaning that in a certain situation, the chances of developing this panic attack become increased. In addition to, so this is basically seen in agoraphobia. So meaning that, and agoraphobia typically occurred in patient who has panic disorder for some times. So initially, if you clock the patient, so you will notice that initially the panic attack are spontaneous. It occur by itself without any specific triggers in the surrounding. But usually patient will try to find out what is the cause of the panic. And soon enough, patients will associate the occurrence of this panic with certain situation like overcrowding, driving under the flyover bridge, for example, being in elevator, away from the house, for example. So this is like classical conditioning. So the panic attack is slowly become associated with certain situation. And very soon, whenever patient goes into this situation, typically in crowded places, away from home, or in places where there is a remote possibility of catastrophe, like boarding an aeroplane, going under the bridge, so patient will become anxious and chances of them to develop a panic attack actually increase. So this is the agoraphobia lah. So we call agoraphobia is established when a patient also has avoidance behavior like prefer to stay at home or avoiding those situations like crowded places, or they may use certain safety behavior like having escort with them. In their mind, if something bad happen, there will be some help to help them out of the problem. And the last one is situationally specific. So this is a panic attack that occur in specific phobia, for example. For example, simple phobia, fear of snake, fear of spiders, for example. So in this type of patient, they only have panic attack whenever they are presented with the phobic stimulus, either in real or in picture, for example. And social phobia, I'm not sure which one. Okay, so basically, this panic attack is like an alarm, it's like car alarm, like the emotion and the somatic symptom that signify whenever there is a threat or danger in the surrounding. So in panic attack, in panic disorder, this alarm triggers off by itself without any triggers from the outside. So this is the essence of panic disorder. Whereas in social phobia, the trigger is social interaction or being in social situation where the patient may be judged or evaluated by other people. And for specific or simple phobia, this is when in presence of the phobic stimulus. And agoraphobia, this occur when patient leave their safe house or safe place and go to the crowded area or whenever lah, maknanya be away from area that they feel safe, typically their own house. So this is how you can view different type of anxiety disorder from the GAD and phobia, as well as the panic disorder. Okay, any question? Okay, kalau tak ada soalan tak apa. Terima kasih. So I think you can read up or watch any resource lah, maybe YouTube ke kan. So you can learn more in detail about what are the cognitive biases commonly encountered in patients with anxiety disorders. So this is good to know because it will help you to understand better patient with anxiety disorders. So cognitive biases is very common among patients with anxiety. But usually we don't use the term cognitive bias in schizophrenia. We don't use that term. This is almost like exclusive term used in anxiety disorders. Okay, that's all. Thank you.
Thank you, Prof.
Thank you, Prof.
Thank you, Prof.